Hello, everyone.
Hi, how are you?
Good, thank you. Okay, I am going to actually be sharing Dr. Zakaria's presentation, and I think he is logging in now. Let me just share my screen, make sure everyone's able to see it. Is everyone able to see my screen okay?
Okay. Mm-hmm.
And Marchette, you'll let us know when you're ready.
I guess give us about maybe 2 more minutes. I'm actually on my cell phone trying to help some people get in.
Okay, no problem.
So we'll start in about 2 minutes.
Okay, sounds good.
Okay. We're ready when you are, Kimberly.
Okay, wonderful. Well, my name is Kimberly Morrison, and I am part of the Corporate Partnerships and Wellness team at Memorial Healthcare System. And I have the honor of introducing Dr. Zakaria. And just to give you a little bit of background on Dr. Zakaria, he is a board certified neurologist who specializes in neurophysiology and epilepsy. Dr. Zakaria earned his medical degree from Damascus University in 1998 and completed his internship in internal medicine at West Virginia University Charleston Area Medical Center in 2005. He completed his residency in neurology at the University of Cincinnati Medical Center in 2008. He completed his fellowship in neurophysiology and in epilepsy at the Mayo Clinic College of Medicine, where he later served as an assistant professor. Dr. Zakaria, thank you for joining, and thank you everyone for taking the time out to attend. I'll turn it over to you.
Thank you, Kim, and thank you everyone for being here today. First, I wanted to be sure that you guys can hear me. So if you can give me a message or can reassure me that you can hear me, perfect. So again, welcome. Thank you for having me. It's just a great honor and privilege to be here with you today to spend some time talking about epilepsy and some of the issues that our patients with epilepsy they have to go through every day, and also, of course, the family and caregivers who also they are living this kind of challenges and sometimes this hardship as they go through day to day their own life. Today, I'm going to be talking about something that we don't talk about much, and this is the sudden unexplained death in epilepsy, or SUDEP. And that's something that, can we move to the next slide, please? That's something I have my own, concerns about talking about this topic to our patients and our families and caregivers who deal with this disease, because it can be scary. I'm not going to be, I'm going to be realistic and talking about death and talking about complication that can lead to death as a result of a disease that you have or someone who you love has. It's not easy. So I really had some concerns about talking about this topic. It's very sensitive. And I know a lot of people might not feel comfortable. So I'm going to give you few seconds. If you don't feel comfortable hearing about this kind of issue or this kind of complication that can happen, I'm going to ask you to please either log off or, I'm not going to be offended, but I wanted everyone to be comfortable talking about this condition, which is a reality that it does exist, as we will see, and we will try to see what are the options we have to reduce the chances of this to happening to any of us. So the next slide. For those who continue to be with us for this presentation, I understand it's going to be a lot of stress and scary talk, but at the same time, if we don't know, we will never get better, and if we don't know, we will not be able to avoid this kind of complication. So it's important to know, it's important to learn, it's important to discuss, and can you hear me?
We can hear you now.
Yes.
Okay.
Yeah.
Okay.
Yes.
So I don't know where I lost you, but what I want to say is that instead of being have that fear of this issue, I think it will be better to get to know what this problem is and why it happens, and what are things we can do in order to avoid going through this complication. So by learning more about this condition, by trying to find the reasons and trying to understand the risk factors, so we try to prevent it. And I think that's the main point of this talk today, is try to prevent this from happening to any one of us. So next slide, please. So especially with the fact that we know that 50 million individuals throughout the world, they suffer through epilepsy. And that means that epilepsy is really not something that's rare or minor. It's affecting a lot of patients from all over, from different places, from different countries. And without increasing the awareness, without working together as one community, we will not be able to avoid such complication. So I think, again, the awareness is the most important thing, because we do have some information, some knowledge about why this happened and what we can do in order to prevent this from happening to us. Next slide. So what's sudden unexplained death in epilepsy? And you can see it abbreviated in the form of SUDEP. Sudden unexplained death in epilepsy is, as it says, sudden unexplained death of someone who has epilepsy. And most of those patients, they are very much healthy. They don't have a lot of health issues to explain the death, except that it must be related to, in some way or somehow, it's related to their epilepsy. So again, it's sudden, which is something that doesn't mean that it happened over time. It's going to be very quick or very fast, very unexpected, when we lose that person who has epilepsy with no really reason for that except the epilepsy. And like I mentioned in the second line, we cannot say this is what we call sudden unexplained death in epilepsy, except after we rule out every other potential reason for that death. So it is what we call as a diagnosis of exclusion. You have to exclude all other factors that could lead to the death. And then if you don't find any reason for that person to die, then you can call that this is sudden unexplained death in epilepsy. Next slide. Someone might ask, wait, what are other reasons? What are other factors that can lead to death in epilepsy that we know? Well, there's a lot of reasons besides some unexplained death in epilepsy that can lead to epilepsy. For example, if someone is in a status, which means that someone is seizing nonstop for a few hours or a few days, then there is a very high risk here of death. And that death, we cannot call it sudden unexplained death in epilepsy, because the death here is related to the status epilepticus, or the fact that he's seizing nonstop for quite some time. Also, patients with epilepsy, they are at risk of going through accidents or drownings. They might have some suicidal thoughts, and they may end up ending their life. They might have some kind of reaction to their drugs, whether it's overdose or side effect from this. All these reasons, if we find any of these reasons, then we cannot call that death as sudden unexplained or sudden unexpected death in epilepsy, because we do have some reasons why this person lost his life. Also, if there is an underlying brain tumor or infection or other neurologic conditions. So the bottom line is to call to this condition sudden unexplained death in epilepsy, it has to be after ruling out almost every other potential reason, every other potential complication that can lead to death. When we rule out all these factors, then we call this as sudden, unexplained, and unexpected death in epilepsy. Next slide. So how often this happen? That's a big question. Is it something that we see every day? Is it something we see a few times a month, or is it something that's rare? I can tell you that, and I'm very glad to say so, that this kind of complication, sudden unexplained death in epilepsy, is quite rare. Again, it's very rare. It affects only 1 of 1,000 people who have epilepsy. They might lose their life from this condition, sudden unexplained death in epilepsy. So one reassuring fact is that it's rare. And if we have thousands of patients, they all have epilepsy, there's a chance of that 1 out of that 1,000 group of patients, they will end up having that sudden death in epilepsy. And even though it's very rare, but it's the most common cause of death in patients with epilepsy. So again, it's very rare, but it can be serious. And that's the whole point of this talk, is try to look into more what we can do to prevent this from happening to any of us. Next slide. So according to the American Academy of Neurology, which is the largest academy of all the neurologists throughout the US and also anywhere else, we have some guidelines and some recommendation that comes from this academy, which is the largest academy for neurologists. And their recommendation is that clinicians or physicians, doctors, should be discussing this kind of issue, the sudden unexplained death, with their patient. We should not hide from this kind of discussion. I know it's not everyone is comfortable, and I know that it's not easy, and that this might bring the fear or concerns. But again, if we don't know, we will not be able to fix it and avoid or prevent this from happening. So the clinicians are recommended or are encouraged to talk to their patients based on the American Academy of Neurology guidelines. They are recommended or encouraged to speak to their patients about the small risk of sudden unexplained death of epilepsy. Like I said, it's very rare. It's 1 out of 1,000 patients with epilepsy, which means that 999 of those 1,000 will be okay. They will not be affected by sudden unexplained death in epilepsy. By the way, if you feel like you would like to ask a question and you don't want to wait till the end, please feel free. I have the chat open. So just type in the question and I will be answering some of this question. I know some of us might forget by the time we reach of the discussion. You might forget the answer to ask a question, or you forget the question. So I have the chat open, I think. So if you have any question, please shoot me the message and we will be talking as we go through this presentation. Next slide. So now we talked about the adults. Let's talk about the kids. Are they also at risk of having this kind of complications, sudden unexplained death? good fact is that this is even more rare in kids than adults. So you remember I told you 1,000 adults with epilepsy, one will of the 1,000 will go through this complication. For kids, you need 4,500 kids. They all have epilepsy, and only one out of those 4,500 kids will face this kind of complication, or they will die suddenly with no specific reason for their death. So it's even more rare for the kids. And like we mentioned, 4,499 of those 4,500 kids, they will not be affected by the sudden unexplained death in epilepsy. Next slide. So here's the question. We said that I have a question here. Let me just read the question and then I will go back to the slide. The question is SUDEP or sudden unexplained death in epilepsy more common with severe cases of epilepsy, frequent seizures, and underlying or additional underlying conditions? That's a great question. We are going to talk about this in a second. So if you give me a few minutes, I have a few slides that will be discussing those risk factors. We call this risk factors. What are the risk factors that can increase the chances of this sudden unexplained death in epilepsy to happen? So the question I had on the slide is, if someone was found dead in bed, and hopefully none of us will be faced with this situation, but if someone was found dead in bed and he has epilepsy, do you have to have a seizure at the time of death to call this sudden unexplained death in epilepsy? Do I need to see the seizure happening and the patient dying directly from the seizure? No. And the answer is no, because you might see the person who's dead, who just had a seizure, or there might be no sign of seizures at the time of death. So the fact that there is no evidence that the patient had a seizure recently does not make the diagnosis incorrect. There is a chance that this person might die from sudden unexplained death in epilepsy, and there is no recent seizure that we can tell. Actually, 1/3 of the cases, there is a sign of seizure or a recent seizure close to the time of the death, which means 2/3 of the cases, you will find that person in bed or on the ground, and he's dead as a result of this kind of condition, sudden unexplained death in epilepsy. So it doesn't have to have a recent seizure in order to call it sudden unexplained death in epilepsy. Next slide. So why it happens, right? So in order to fix it, in order to reduce the chances or to prevent. So now we start talking about prevention. So why it happens, why seizures can lead to this awful complication, sudden death in patient with epilepsy. The bottom line is we don't know. But I want you to look at the connection that exists between the brain and the heart, between the brain and the lungs, and the brain and the other structures in the brain. So you can see in this, I wish there is a pointer. I don't know if I don't think there is a pointer, but you can see that there is that connection that you see between the brain on the top during the time of the seizure and the effect of that seizure on the lungs. What kind of effect that the seizure will have on the lungs that can lead to death? The second connection is between the brain and the heart. When someone has a seizure, what's the effect of the heart as a result of that seizure? And the third question, or the third connection, is between the brain itself and the other vital parts of the brain, the other important structure of the brain that might be affected during the time of the seizure. So let's go more in depth, trying to analyze this connection between the seizure and the different organs, the heart, the lungs, and the other structures in the brain. Let's go to the next slide. So what's the effect of the seizure on the breathing? There are some evidence that during the seizure, there will be, the patient might stop breathing, or might not stop breathing, but might have a problem getting the air inside the lungs, in and out, having a blocked airways, which will lead to suffocation. So one potential reason why this happened is that because the brain, during the time of the seizure, the lungs will, the connection between the brain and the lungs might stop working, and there will be no oxygen, or there will be no exchange of oxygen in the lungs. And as a result of this, the patient will not be able to breathe and he will die. So that could be one potential reason why this person died, is because his lungs, he stopped breathing as a result of the seizure. Or sometimes can be because of the blockage of the airway. For example, if he has a lot of secretions, if there's a lot of saliva, if there is a lot of, if his tongue is sticking out in the back of his mouth, all these things might block his airways. And when you have this blockage of the airway, then you will not be able to breathe. And that can lead to sudden unexplained death. So the first thing, the first connection is between the brain and the lung. And we talked about the potential risk of the lungs being stop breathing, or to the blockage of the airway. The second connection could be between the brain during the seizure and the heart. So sometimes we know that there is an effect of the seizure on the heart. And we know that most patients with seizures, when they are seizing, the heart rate goes up faster. And sometimes they can go into a irregular heartbeat. And sometimes they can go into a very dangerous heart rhythm, or the heart might completely stop. And that's what we call cardiac arrest. And that can happen. And that could explain the death in this condition, is the effect of the seizure on the heart. Still, the patient might be able to breathe, but there is no heart, there is no pump of the blood to the lungs and to the brain, and that can lead to death. So those are two of the three connections that we mentioned. And then the third reason, or the third connection, is between the different parts of the brain itself. So during the time of the seizure itself might suppress the function of other parts of the brain, mainly in the brainstem, which is a very critical area that keep us alive. And if there is a problem with that function of the brainstem, then the person might end up dying as a result of the seizure. Next slide. It also talk about this more in details. So we said that when there's a seizure, there are three potential reasoning why this patient might die. I'm going to start with the far my right, so it's going to be on the right side. It's because of the effect of the seizure, it can affect the heart center in the brain, and that, if you follow the arrows, it will take you to the cardiac dysfunction, which means the heart will stop not functioning right, especially with the rhythm of the heart. The patient might have arrhythmia, which means the irregular heartbeat, or asystole, which means that the heart will completely stop, and that can lead to death. The second potential reason is the effect of the seizure on the breathing center in the brain, and that can lead to stop for the lungs to not being, the lungs will not be able to breathe, to exchange the oxygen, and can lead to stop breathing, and that can lead to death. And then the third potential reason is the spread to the important part of the brain that control our arousal, and as a result, there will be a problem with breathing, and that can lead to eventually death. Now, look at some of these factors that can make things worse on the lungs. It's in the left corner part of the slide. If someone is facing down during the time of the seizure, that will increase the chances of having that problem, the lack of breathing. That's why it's extremely dangerous to have a seizure and your face is down, facing down, because it might compromise the airway and compromise the breathing. The second one, if someone who already has a sleep problem, especially sleep apnea, you have a person who's already struggling through his breathing, and then you add to that the seizure and the effect of the seizure on the breathing, that can lead to even worsening or increase the chances of death. So let's go to the next slide. I do have some questions. I'm gonna try to answer. So before we talk about the risk factors for death, I have two questions. The first one, brain bleed caused by seizure increases chance of SUDEP. I'm not aware of any studies or any data to suggest that brain bleed during the time of the seizure will increase the chances of sudden unexplained death in epilepsy. Of course, brain bleed can lead to death, but it will not be called as sudden unexplained death. The second question, how the person can be found face down and not necessarily have a seizure in the moment, yet the cause can be still from the sudden unexplained death. Does this result as a seizure from earlier in the day that disturbed the breathing, heart rhythm, brain function? Yes. So it could be a seizure that's earlier, or could be a seizure, a silent seizure, in a way that the patient had a seizure, but there is no evidence that the patient had a seizure. But maybe during sleep, the patient had a silent seizure, and there was no clinical symptoms that suggest that the patient had a seizure, but patient indeed had a seizure, and that what led to the breathing or the heart problem dysfunction. If it doesn't make a lot of sense, just respond back to me through the chat and I will explain it more. But when we say that there might be no evidence that the patient had a seizure, does not mean that patient did not have a seizure. There might be had a seizure, the patient might have a seizure, but it was a silent seizure during sleep, and we cannot tell 100% retrospectively. So this is the most important slide now, which is what are the risk factors for the death? Which patient is at a higher risk of going through this or facing this kind of complication? And the reason why we want to know the risk factors is because we wanted to see how we can prevent this from happening. This is the key, how to prevent the seizures from happening. So let's go over the slide. Story. I know there's a lot of numbers. I don't want you to worry too much about the numbers, but let's go over the slide step by step. So the first one is the first factor that increased, and this is, I took this slide from the American Academy of Neurology, which is again the largest academy of neurologists in the United States and everywhere else. And this is the guidelines that they published a few years ago. The first one is the fact that your seizures are more intense or severe seizure, which we'll call them as generalized tonic-clonic seizure. So if you see GTCS, that stands for generalized tonic-clonic seizure. In the lay language, we call it a grand mal seizure. So the person who's having grand mal seizure, which is seizure described as, the patient on the floor, shaking everywhere, his eyes are rolling back, and he is convulsing in both arms and legs. That kind of seizure does increase the risk of seizures. And I want you to look at the number 10 here, the odd ratio. The odd ratio means the chances of this comparing person or a patient who does have this kind of seizure to the person who does not have this kind of seizure. He has 10 times more risk. Again, 10 times more risk of death from epilepsy if you have generalized tonic-clonic seizure or grand mal seizure compared to someone who does not have this grand mal seizure. That's one thing. The second thing is not the fact that you do have it. The fact is how often it happens. So you see the frequency of it is also quite important. For example, if you look at the explanation here, if the person is having 1 or 2 grand mal seizure per year, his risk is 5 times more than someone who has no tonic-clonic seizure. So if only 2 seizures per year, the risk goes up by 5. But if it's more than 3, the risk goes up by 15. 3-fold increase in the chances of seizure if the seizures are more than 3 seizures per year. And that's something we have to keep in mind because by controlling those kind of seizures and trying to limit the frequency of the seizures, we will see we will have significant reduction of the risk of sudden unexplained death in epilepsy. Some other risk factors is if patient continue to have seizure, he's not seizure free. That's also another reason or another risk for having a sudden unexplained death. That's why we always talk to our patients that we really wanted to get you seizure free. That's the goal of our our treatment, is to provide you with seizure free. Having few seizures a month, it's still a significant thing that we need to address. Some other risk factors is not adding another seizure medication. Sometimes patients will say, I don't want to take more medication. I'm taking so many medications. And if you continue to have seizures and nothing has been done, no medication's been adjusted, no medication's been added, then that will also increase the risk of the seizures. Now, there's also this something that I want to mention, but I don't want you to be very overwhelmed about this about these two factors. If someone is taking his, protecting himself by sleeping on his back and preventing sleeping facing down, or you have some family member, your relative, who they check on you and they always put you on your back, especially during sleep. Or if you have one of those listening devices that will wake you up if you are changing or you are facing down, those kind of measures, they will reduce the risk of sudden unexplained death in epilepsy. So you see the numbers for the last two lines here is 0.4, which means that there will be a reduction of the chances of this to happen if you just try to sleep in a position where you are not increasing the risk of having sudden unexplained death in epilepsy. Let's go to the next slide. So some other factors that might, it's very, we don't know. The one I mentioned are definitely the one that increase the risk of seizures. There are other factors that maybe we're not sure. So what are some of these factors? Having seizure during sleep might increase the risk of having seizures. If someone has seizure during the day and seizure during the night, the person who has the seizure at night has a higher risk of seizure if death from the sudden unexplained death in epilepsy than someone during the day. There are some theories, but I don't know how accurate, is that there are specific medication maybe associated with increased that risk. For example, Lamictal, but that's something that's very controversial and is not proven. Person who is having seizure, never been on medication, increased risk of death. The number of seizure medication you're using, so of course, the more numbers you use, that means that's more refractory your seizures, the more likely you're having big seizures, the more likely you will have this complication. If you have some kind of change in the heart rate, your heart rate sometimes it goes too fast or too slow, that's will not increase the risk of seizure. The changes in the heart rate on day-to-day basis. Again, all of these are very controversial. I just want you to kind of see if you do have any of that risk, then you can talk to your doctor, but those are not proven facts. Again, they are coming from the American Academy of Neurology, but they are not proven fact to cause sudden death in epilepsy. If you have extratemporal epilepsy, which means seizures coming from somewhere else beside the temporal lobe. If someone is mentally challenged, men are at higher risk. You can see the picture here. The men, especially age 20 to 40, are at a higher risk of seizure. And also using some medication that suppress your breathing, like if you're using a lot of Xanax and Klonopin and all this medication in a higher dose, they might increase the risk because, of course, it's going to suppress the breathing, and then you have the seizure, which make it even worse, and that will increase the risk. Again, this very controversial, low risk, but I wanted to mention it just in case you heard somewhere else. The next slide. So again, some of those very low, controversial, maybe conflicting evidence to support the correlation between these factors and death. But the first one is the frequency of all the seizures. We talked about the frequency of the big seizures. They do increase the risk of seizures. But how about all seizures? The frequency, the more seizures you have, the increase the risk. It's possible. Also, if you are on multiple therapy, multiple seizure medication, we talked about this. We mentioned that also if you have mental health problems or lung disorders, if you drink a lot of alcohol, definitely. And if your medication, you're not taking your medication, if there's a lot of changes in your seizure medication with no reason, that also can lead to maybe increased risk of having death of epilepsy. Next slide. So as you can see, it's very complicated. There's a lot of factors that's playing a role in this complication. We said young age, 20 to 40, especially for men, that's a risk for death. Frequent seizures, especially tonic-clonic seizures, is also another risk. If that is combined with sleep or prone position facing down, that definitely will increase the risk. Maybe there's some genetic, we don't know, maybe there's some genetic predisposition that can lead to that complication, which eventually will lead to death. So it's a very complicated model. The bottom line is we really don't understand much about why it happened. We have some theories, but we do have, the take-home message is the two risk factors that definitely increase the chances of having this complication will be one, having tonic-clonic or grand mal seizures, and the second factor is the frequency of this tonic-clonic seizure. We have a very strong evidence to suggest that these two factors increase the risk of having sudden death. So how do we prevent this from happening to any one of us? Let's look at the next slide. First of all, is to reduce the risk is please take your medication. It sounds very simple and very easy, but you cannot imagine how many patients I see every day that they can do better with medication. So remember, epilepsy is not an easy disease. It's not a benign disease. I don't want to spread fear in between us about epilepsy. However, I wanted to mention the risk of not taking care of yourself and taking care of your seizures. And the simple and the most effective way to stop the risk of death in epilepsy is to take your medication as prescribed. If you are taking your medication and you're still having seizures, then we do have a lot of other options to adjust either to adjust the medication or to speak to your epileptologist about advanced treatment options, whether it is devices or surgeries or anything. There is some data that suggests that surgery or devices that help to control the seizures might reduce the risk of sudden unexplained death in epilepsy. So it's very important to take care of your seizures in any way, any method possible, whether with medication, adjusting the medication, or speaking to an epileptologist. If you're having frequency, if you have failed 2 medications, if you try 2 different medications and you failed them, you're still having seizures, it's time to speak to an epileptologist and being seen in advanced epilepsy program. So you look at your options and you talk about your risk and you see how you can reduce that risk. The next question. The next slide. So other steps that also might help. Seizure triggers. If you know that drinking, I have a patient who has seizures only when he drinks. And I told him, I'm not going to keep adding more and more medicine just to stop the seizures, while you can take care of this by reducing or to stop your drinking. Another thing is the flashing light. I just saw a patient 2 days ago who his seizures or her seizures are induced by flashing light. So whatever triggers that you can think or you have noticed can lead to your seizure, stay away from those triggers. If you want to talk more, there's an Epilepsy Foundation website that you can talk about seizure trigger external icon, I guess, and you can have that chat to see what are might be some of your triggers that can lead to seizures. Avoid drinking too much alcohol. That's something I cannot emphasize enough. I wanted to mention that you should not drink, especially in case that your seizures tend to be triggered by alcohol, like that patient I just described. For those patients, I would say 0, no alcohol. It's not worth it. And if you really want to drink, then do not drink too much. Just maybe one alcoholic drink, and that's it. And that's maybe once every few weeks or so. We talked, and I'm going to talk about this in a second, self-management programs, which mean things that you or your caregiver can do to you while you are having seizures. And we'll talk about this in the next slide. Enough sleep is very important. And like I said, the seizure first aid by talking to someone who lives with you so he can be helping you during the time of the seizure. So let's go to the next slide. So those are very common questions we get. What do I do when someone is seizing? First of all, you have to stay calm. Do not panic, because if you panic, then you're not going to be able to help yourself and help him. Stay calm with that person until they get back to normal, until they are awake and alert. Be sure that this person is in a safe space. Be sure that this person is not falling, or he's not hitting the ground, or he's not hitting his head. So be sure he's on the safe place, safe space, and then also try to put him on his side. Could be the right or could be the left. And that's the reason why for that is to avoid the blockage of the airway that we discussed earlier, by preventing the secretions from building up in his lungs, and also prevent his tongue from pushing back in his throat. So those kind of things, to roll on the side and put a pillow under the head is something that can help to avoid this kind of complication, death in epilepsy. Time is very important, so to keep an eye on your on the time, how long it's been, and if it's more than 2 or 3 minutes, you got to take that person to the hospital, because the seizure might last a lot longer, and then that he will be at risk of death from that seizure. Try to provide reassurance for that person. You call 911. When do I call 911? If the seizure lasts more than 5 minutes, of course, or if the person is injured or sick, or if he has 2 seizures in a row without going back to normal. All of these are signs that there is something going on. You better call 911 so they can take him to the hospital. Do not restrain that person. So I have even sometimes nurses, they'd say, oh, can we restrain that person? You cannot. You will break the bone and dislocate the joints if you do that. So do not restrain the person, and do not put anything in the mouth. I hear some patients, they want to put their finger so they can be sure he's breathing, or to put a spoon in his mouth. And all of this can lead to a lot of complication, can block the airway, can break the teeth, can lead to a lot of issues. So stay away from any of this kind of act. Excuse me. And the good thing also that we have a lot of newer medication that's been approved recently. Those medications are either through in spray. They are this either nasal spray, or is a excuse me. So it's either a spray that you can spray in your the person around you can spray in your nose to stop the seizure right away, or it's a small something you put under your tongue that help to also end the seizure. So I know in the past we used to have the rectal diastat, but using this rectal approach might not be the most convenient way. So now there's a lot of newer options that we can consider to stop the seizure right away and reduce the risk of death in epilepsy. The next slide, I think there's only 2 more slides and we will finish. So I wanted to encourage every one of you to talk to your healthcare provider, your physician, your epileptologist about this, and talk to them about the risk for this and what you can do to reduce that risk. And what should you do if you forget taking anti-seizure medication for 1 day? I will tell you the answer for that right now is to go ahead and take it with the minute you remember. And then when the next dose, the time for the next dose comes, you take the next dose as if nothing changed. So let's say that you missed the morning dose, okay? And now it's 5 p.m. So you missed the morning dose and it's 5 p.m. So you go ahead and take the medication at 5 p.m. Now you were supposed to take the medication also at 7 p.m. That's your second dose. You go ahead and take the medication at 7 p.m. So you just take the medication you missed right away, and then you continue with your schedule as if nothing has changed. Talk to your physician if you should change your seizure medication. There's a lot of newer medication that came out recently, and some of them are really effective. So try to do not give up. If you feel like your seizures are not going away, then you continue to try different medication that you try. If they decide to make a change in the medication, talk to your provider. Why are you giving me this? Why you're not giving me that? Why are you choosing? So there's a lot of questions you can ask. What's the side effect? What's the efficacy of that medication? All these are important. Is there any specific activity I should avoid? Like if you are you're still having seizure, you cannot swim, you cannot of course you cannot drive, you cannot bike in the street between the cars. So all of these things try to avoid that might reduce the risk of death in epilepsy. And we talked about some of the instructions that you can teach your family and your friends if you have a seizure. And by the way, if anyone is interested in a copy of the PowerPoint, I'll be more than happy to send it to Kim, and she will be sending it to anyone who's interested. So you can go over the slides and reread the facts. So the next slide, the last slide I have here, which will be the conclusion. Can we see the next slide, please? Okay, so remember, SUDEP is sudden unexpected death of epilepsy. It's one of the most common reason for death in young adults with uncontrolled seizures, but it's very uncommon, especially in kids. Remember, 1 in 1,000. We mentioned some of the risk factors of SUDEP, especially the fact that the tonic-clonic seizures, the frequency of the tonic-clonic seizures, those are the two most important risk factors that we really need to try to avoid. And again, the talk was not meant to spread fear or anxiety, but more to get some knowledge and facts. So can we work all together so no one of us will be facing this kind of complication in the future. With that, I wanted to thank you all for your attention. It's been a pleasure. Like I said, it's a privilege to be with you today. If you have any questions, please you can let me know. I do see a lot of people asking for a copy of the PowerPoint. So definitely, actually, I already sent it to Kim, and Kim will be sending this to the Epilepsy Alliance, and they can forward this to you. Feel free to go over it, share it with people you know. There is no copyright here reserved. And if you have any questions or I can help you with anything, please reach out to me. One of the questions is, when changing medication, is it necessary to go into the hospital for monitoring? If not, what's the method of weaning? That's a good question. I mean, that's something you have to discuss with your provider. It all depends on how fast we need to change the medication. For example, if someone is experiencing a lot of side effect and is experiencing a lot of seizures, maybe changing the medication at home is not the best thing because it's going to take a long time. So if you're having some side effect and if you are at risk of having more seizures, then maybe changing the medication in the hospital might be an option, especially if there's an EEG monitoring that can help you to record the brain activity and see if the brain activities is getting less or more. But if your seizures are not too bad, you're doing okay, and the medication, the side effects are not extremely severe, then you can start the slowing or titrating up and down of the medications over a period of time. And that might be also another option. So it's really based on the individual information or the individual case, which option would be better, whether it's medication in the hospital or at home. Any other questions? Okay, so I will end here. There's one more question. What do you think about Epidiolex or CBD? So it's like any other seizure medication. I think it's worth to try. It does come. One of the important things we learned about the CBD, medical CBD, is that it does come with side effects, and mainly it affects the liver. So you will find that your doctor, if he's prescribing this medication, they will monitor your liver enzymes and be sure that your liver is not. So even though it's very natural and it's very, medical marijuana, but it does affect the liver, and also it does affect the interaction with the drugs. So the CBD can affect the concentration of the drugs. So it's important to have this done as under supervision of the provider. Okay, well, it's been a pleasure talking to you all. Oh, one more question. May I be send the PowerPoint as well, please? Yes, we will send the PowerPoint to all of you. And again, you will have my number. If there's any question you would like to talk, I'll be more than happy to answer. Again, the point of the talk is not to spread fear or anxiety, is more to spread fact and shed some light on this issue, so no one will go through this. Again, I wish you all the best. Thank you for being here today.